colleagues. And with that, I'd love to introduce my co-host on today's journey, Dr. Ari Hoffman, who's our Senior Vice President of Product and our Chief Clinical Officer. Ari, you want to take a minute to introduce yourself?
Hi, everyone. Ari Hoffman. I'm an internal medicine doc by background and joined Collective Health from a career at UCSF, University of California, San Francisco. Been at Collective 3 years. And it's been a great privilege to be a part of both the clinical org and the product development org. I serve product management, design, insights, as well as our clinical team, which includes our care management and our population health teams. Great to be here.
And so with that, let's dive in. Our goal here is to spend about 30 minutes walking through a couple of big ideas. And the big ideas are really around how at Collective Health we think about delivering a benefits experience that's not only a better experience, but probably first and foremost, how do you also directly address healthcare costs at the same time? With that foundation, we're going to go into what I think most of us are excited to talk about today, which are our guide plans, which is a new thing at Collective Health that we think really threads that needle between how do you lower costs and deliver a better experience at the same time. We'll quickly end with what's next for Collective Health. I've had the privilege of being at Collective Health for a decade, and I know many of y'all knew Collective Health 10 years ago, 8 years ago, 6 years ago, 4 years ago. I would encourage you that if you haven't heard from us in the past few years, it's probably time to check in with us again because we're really speeding up the pace at which we're bringing innovation to market, and we're excited to have those conversations with you. So with that, my job right now is to give a bit of a foundation on Collective Health. Then I'm going to pass it over to Ari to really dive into guide plans. What am I excited about at Collective Health? It's really the idea that at Collective Health, we think not only is it aspirational, it is absolutely possible. That with Collective Health, we think we can help you drive more than $1,000 per employee in annual savings and deliver an experience that your people love. Historically, you've had to often choose. Do I want to focus on member experience, even if it means writing a bit of a blank check? Or do I focus on cost savings, knowing that's going to represent some member disruption? I think at Collective Health, our journey over the last decade to where we are today has been that's a false trade-off. If you do your job correctly, if you work with the right partners, you can both unlock significant savings and deliver an experience your folks love. How do we do that? At a high level, you can think about Collective Health as bringing the pieces together through an integrated platform, but not platform in the sense that it just sits on top of everything. You look at the bottom left. Fundamentally, we are a TPA. We are the ones processing plans, adjudicating claims, really running the day-to-day. But we do that in a way that we're also navigation and advocacy. We are the digital experience. We are the telephonic experience. We're who you call with questions. We're also who calls you to help you navigate complex clinical needs. Historically, our space is often thought we'll use a TPA for the back end and maybe put in a different solution on the front end. We think that's one approach. We don't think it's the best approach. We think Collective Health being the TPA on the back end and the member experience is huge. Not only is that huge, but we also think there's an opportunity to simplify life for your members even further. That last part, Benefits Hub. Let Collective Health be where people go for medical and for pharmacy and dental and vision. Let's make it even easier. Let's add 401k. Let's add life, disability, ancillary benefits. We think there's a huge opportunity for your members to not think about I go here for health benefits and I go here for everything else. Let's bring everything together through Collective Health. So keep that in the back of your mind when we think about guide plans. We are the TPA on the back end. We are also the member experience on the front end, and we're doing it in a way that allows you to bring it all together in one spot for your folks. Here's an idea that Ari and I talk about a lot that I think really gets to the core. And if you want to understand Collective Health, it's understanding this slide. We think there's an opportunity to offer the flexibility of carved out with the simplicity of carved in. That's our ethos here. What do we mean by that? I think too often employers and consultants have a really tough choice. Do I carve everything out to best-in-class vendors? And I'm confident they're the right vendors, but it's a member experience maze that no one understands, or it's an administrative nightmare with eligibility and claims and payments going everywhere. Or do I concede? Do I carve everything in through one vendor, Maybe it's not the best mix of programs, but at least it's easy to run and it's easy for members. You just say, go here. Collective Health, we think you can do both. We've built the administration on the back end to mix and match medical, pharmacy, dental, vision, point solutions, different vendors, so you and your team can feel really comfortable that is the right mix of programs to really bring your benefit strategies to life. But on the front end, it's Collective Health. Your members have one app, Collective Health, one search bar, one phone number to call, one advocate, one navigator there with them on that journey. We really think this represents a better model. You're not choosing between carved out and carved in. You have the flexibility of carved out on the back end with the simplicity of carved in on the front end. That's what I get excited about. I also think when you start to marry the back end administration with the front end member experience, that's where you can really start accelerating on things like plan design that are not only an administrative challenge, but also a communication challenge to members. I don't think this is just a good idea. I think it works. In fact, for those of you that have not heard proof points from Collective Health recently, it works really well. For our clients who are rolling out the guide plan, we're seeing $77 at PEPM employer savings. Because we're the back end in a really flexible way, we can do payment integrity in an interesting way. We're seeing $35 in PEPM savings. We can do either on our own or through vendors, but bringing that really integrated into the administrative and member experience, there's value there. On the care navigation side, care navigation is what we call our high touch navigation advocacy program, significant savings from that. And these other carve outs, point solutions, other things we can do. This is where I start to get excited about driving real value to your organization. $1,000 per year in savings. But where we started, you do it in a way that members love their experience. Let me walk through these stats. 2/3 of claims dollars are preceded by an engagement with Collective Health. What does that mean? That means that we are so engaging and members turn to us so often that 2/3 of the time they're connecting with us before they touch the healthcare system. That gives us such a strong opportunity to help them make the right choices. Next, we know healthcare is messy. We're proud that as we've scaled over the last decade, our net promoter is as strong as ever. Net promoter score in the 70s. Finally, on the right there, we know that affordability is on everyone's mind, but I think it's important to realize there's two parts of that. There's employer affordability, but increasingly member affordability. You cannot just shift costs to members. There is a breaking point there. We think things like our guide plan not only delivers value to the employer, but we're seeing 50% lower out-of-pocket costs for members. Why? If you design plans that are understandable, that are clear, that have the right incentives, members do the right thing. That helps their organization. It also helps them. And these things lead to, I think, if you haven't paid attention to Collective Health recently, how we've grown to one of the largest independent TPAs out there. 625,000 members nationwide, more than 140 integrations, more than 800 employees working together across a great set of organizations, some high tech, some distribution, some retail, some manufacturing, and really setting a standard, whether it's on member service, security and infrastructure, NCQA accreditation on our care management programs. These pieces come together to really deliver both the cost savings and the member experience. I could talk about that a lot, but with that foundation, I want to pass it over to Ari to talk about a specific thing that we want to dive into today, our guide plans at Collective Health. And so, Ari, let me pass you the baton to spend a little bit of time on guide plans.
Thanks, Kirk. Sorry for that slight delay. I was answering Mitchell's question in the chat about care navigation partner, and just want to let everyone know that. So our care navigation product is in-house capability at Collective Health, and I laid out a little bit of the detail there. This is something I really love to talk about, and just to go back to my background, I mean, I spent some time in DC, on national health reform, in the early Obama administration, a lot of health policy, a lot of medical center and multi-system work across the state of California, the University of California med centers. And really the focus, if I could pick one word, has really been about value. I was a value improvement director at UCSF and led a lot of initiatives to rethink the way that we approached value. And one of the most important things for me was really thinking about the human scale of value improvement, because I felt like so often the individuals were lost in the conversation when we talked about things at the national health system level, or even at the med center, a large delivery system level. And so affordability, to me, things like affordability at the member level, super important to center that. Things like, how do we create some principles around guiding people to better value, such that we're not actually like penalizing people for stuff that they don't even have agency of choice over. So I think you'll hear a little bit of that, and I hope you sense my excitement already as we go into these next slides. So I think it won't be news to anyone that this has been in the news a lot. It's kind of a hot topic in the industry right now to think about alternative plan designs or the idea of simplifying the healthcare journey. I think a lot of folks have come to realize that high deductible health plans over the course of many years, really like a 15, 20 plus year experiment in high deductible health plans and sort of shifting some of those costs to members to make members more savvy shoppers of healthcare through more skin in the game, if you will. A lot of that has fallen short of some of the expectations, and in fact has created a lot of pain points, right? The whole concept of underinsurance. And so our hypothesis is that these high deductible health plans and other complex plan designs often confuse members, and even well-designed, if members don't understand and know how to navigate their care, that the plan designs will not meet their intended goals. And that quality variation is still a huge part of the healthcare landscape. We see wide variations in practice patterns, and the data available to understand those practice pattern variations and help target better value across the system has really changed the landscape. So our solution is to create a clear, easy to use plan design model that simplifies member decision-making and drives people to higher quality care at lower costs. If you can go to the next slide. So we have sort of three main principles here, or tenets of our guide plans. That there's transparency. So these are copay-based designs so that a member knows upfront in the sort of search experience or shopping experience, if you will, that it's actually informed, that they actually can, that they're shopping for something that they can know at that time. So we don't think it's fair to ask a member to know what they might be diagnosed with or what CPT code might get billed after a visit when they're searching for care that hasn't yet happened. That's not real transparency. That's not fair or easy, right? And so we want a copay-based design, so it's dollar signs, not a percentage of a number that they don't know. And it's easy. There's a clean and clear member experience, and of course that it's evidence-based, that we're using provider-level data to help members find the highest quality care. One thing I'll say about quality is you'll see that there's a lot of different versions of quality out there, and we have felt that it's really important to center appropriateness of care and not hide things like, just network discounts for cost efficiency as the primary sort of euphemism for quality, but to use real clinical outcomes and appropriateness of care as the center. If you can go to the next slide. So again, to like, what are some real member-centric ways to think about this? It's like, goes back to what our members actually need and how do we think about those needs? So I need to find a doctor. We know that the care finding experience is critical, and it's often a huge pain point for people. They don't have the information they need. And so by introducing provider level quality scores or value scores, the best providers can show up first, and we can present upfront cost via co-pays in the search experience, embedded in the search experience. Then a second category might be a specific need. I know I need to have surgery, or sometimes I think I need to have surgery. And then to be able to ensure appropriateness, is there a more conservative pathway that might be appropriate in this case and actually avoid a potentially unnecessary surgery? Or if it is appropriate and necessary, understanding subspecialization and practice pattern variations within a geography that's accessible to the member so that the best places can show up first and again, see upfront costs via copays. Or I need an infusion. We help you find the highest value location for that infusion. And we found, I mean, you can go real deep on any of these rabbit holes, and I'm excited for the questions that come up at the end. But just an example I like to give about the complexity underlying some of these, the value guidance, even for a single drug like Remicade. Remicade, a single member on Remicade could have 32 different permutations for changing where that Remicade is given or whether there's a biosimilar available. There's formulary implications, all these different data points. And so to optimize for affordability, it's actually a complicated data science experiment in itself on that single drug. So that's the work that we're trying to do to take the homework out of healthcare for people and to help guide people to the highest value location and optimize for affordability. So what this looks like for member, from the member standpoint, with three pictures from left to right: the phone, the computer, whether it's mobile or web portal, an example of our Get Care section of our member portal. And this is a sort of a generic example where you can see a preferred provider badge. I'm not sure how well it's showing up on everybody's screen, and it's a little bit small, but you can see a sort of gold colored badge for preferred provider with a little star. It's got a copay underneath it. And then you can see a provider score, which actually has some details about top specializations, as well as, if the member so chooses, to dive into the components of that score or the explanation behind that score if they hover over that. And then on the right, there's a picture. This is a picture of Melissa Selden, who's one of the leaders of our care management team based out of our office in Lehi, Utah. And this is just to make the point that these same tools power the people who are member facing, whether that's our member advocates on the phone or our care navigation team to support the type of guidance that we would give members if they're calling in or connecting with people via other communication channels, whether that's text, chat, whatever. So an example of how this looks, again, to Kirk's point about front end, back end, right? We're tying together a simple and streamlined front end with a back end that uses a tiered plan design structure that's built out based on provider quality and other components of value. So this is for illustrative purposes, and it's somewhat simplified, right? So obviously a plan matrix would have a lot more detail than this, but the idea is that tier one would, there's a couple different ways to think about this. One is an incentive plan design. We're trying to drive people to a narrower slice of the very top scoring providers. We're picking a random number here, like say 30%, the top sort of third. And then the remaining 70% in this example would be in tier two and we're giving examples of $1 sign, $2 signs, $3 signs as you go from left to right, for tier three being out of network. And disincentive would be, well, at least, for access reasons, maybe once we take into account certain geography limitations, that we'd want to expand tier one, but really try to avoid seeing the lowest quality providers. And so you can have more of a disincentive design where tier one is a broader network or tier, and then tier two is just those bottom 25%, say, and then again, out of network. Now, this is, again, exact values would fluctuate, as well as a lot of other configurability with respect to the construction of the tiers.
All right, it's fair to say, though, it's not fixed. It's more of a framework for how we can work with employers and consultants. Is that fair?
Exactly. I can always depend on you to take what I'm saying and make it even more concise. Thanks.
But I think it's worth diving into for some employers. The key thing is how do we drive people to the best providers? Some have a pragmatic concern. What if they can't get in to see the best providers? So then maybe in that situation, the key thing is to keep them away from the bottom quartile of providers. Like that's the nuance that I think collective allows you to have is what are you trying to accomplish and what's the right way to accomplish that? Because if you get this right, a lot of good things happen.
Absolutely. So I'll speak a little bit to some of the impacts. So how guide plans drive impact, and we'll speak to some of the proof points, and then wrap up with plenty of time for questions. So several ways, right? Hopefully this may be stating the obvious, but just to talk about, there's some near-term or short-term plan savings. A lot of that, the immediate claims-based savings, do result from optimizing the routing of members to lower cost sites of care, especially when there's lower cost alternatives. And building that in a plan design helps us take a navigation function and tie an incentive, a member financial incentive, to make that choice that will be more affordable to them as well as more affordable to the plan. Long-term plan savings. So a lot of the appropriateness really comes into play here, right? So a more appropriate care can help improve health and then avoid downstream complications like landing in the ER unnecessarily, or the example of musculoskeletal surgery being on a more appropriately conservative pathway, like virtual or in-person physical therapy, that often negates the need for even the specialist visit, the MRI, and the potential surgery down the road. And then, of course, improved health outcomes ties also to appropriateness through, and we see that in increased adherence to HEDIS guidelines and measures. And then a better member experience, we think, by reducing plan complexity and providing personalized and proactive and easy to understand support in the language and the tools, from the get-go, how members understand and navigate their plan all the way through to how we hold their hand and help them in those moments of finding and accessing care. We think that's really important. And it, again, gets back to why our thesis is that the front end and the back end have to be together, or that they're at least more powerful when put together.
All right, expand that a little bit. Better member experience. Why are copays so useful there compared to coinsurance, for example?
Coinsurance confuses people. People just don't understand it. And I think we, in the industry, we get used to these terms. But, I think it's always telling to me to go back to some of the data from like Kaiser Family Foundation surveys. And I won't have the number at the top of my head, but, it's a majority of people who can't define premium, copay, coinsurance, and deductible. It's really hard for people to understand. And again, to my point, when you're at the point of search, when you're trying to find care and make a decision about where you go next, you don't yet know what the procedure codes are going to be or the diagnosis codes. So the coinsurance is a percentage of a number you don't know. And that's pretty much meaningless for making a financial decision. But, the difference between 0 and 50 or 100 or even hundreds of dollars, that's really obvious to people. They can make a more informed decision. So a couple of the proof points, just on guide plans, we see $77 per employee per month savings. We just had a peer review by the Validation Institute, validated for those savings numbers. So you have 50% reduction in member out-of-pocket costs. So this was 367 annual out-of-pocket costs versus a national average that we see in the 800s. 75 net promoter score, and really, I was blown away by some of the magnitude of the effect on things like preventive service care, especially because we fancy ourselves pretty good at this already at Collective Health, but we saw really big bumps in higher preventive care utilization than industry benchmarks. So if you go to the next slide, I already mentioned our Validation Institute peer review. Happy to talk more about that in the Q&A. And then I think if you go to the next slide, Kirk, I'm going to hand it back to you. Do you want to take a minute now to answer some of these questions, or do you want to wrap up with what's next and do all the questions at the end?
Good question. Let me get through the next couple, and then we'll take a deep breath and just start talking. How's that sound? All right.
Sounds great.
So we spent the last 10 minutes talking about guide, and that's kind of a key framework within collective health. One of the ideas, along with the back end and front end, and I want you to take away is benefits are complicated, to make the most obvious statement of this webinar. And it's complicated because there's so many moving parts. Network, tiering, plan design, payment integrity, care management, point solutions, engagement, advocacy, proactive outreach. And the reality is they're typically not connected. Not only are they not connected, you suffer from that disconnect. Your members suffer from the disconnect. Also, your ability to impact change or speed to innovation suffers because you can say this year we're going to focus on the red puzzle pieces. Next year we'll focus on the yellow puzzle pieces, but it turns out they're connected. You can't do plan design without doing member engagement. One of the things about collective health is because we spent 10 years building such a robust foundation, we're the ability to say, no, 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 it's not the yellow pieces this year and the blue ones next year. So let's figure it out together. How does plan design impact member experience? I saw some great questions about things like carve out centers of excellence. Let's make sure we can bring centers of excellence fully into it and weave them into plan design. Let's make sure our care navigation team, again, our in-house team, has this plan design in mind when they're guiding their members to the right care. When you start to connect all these pieces, not only is it a member experience, but I would argue the impact of each of the puzzle pieces becomes even more powerful. That's why we are such a firm believer that you can't just be the TPA or just be the member experience. It's when you put those two together, that's where you really start to make an impact. And guide is just one of the things we could have talked about today. For those of you that have not heard from Collective Health lately, a few things that we've rolled out recently, Benefits Hub. Historically, we've talked about collective health as being where you start from medical and pharmacy, but now let's add dental, let's add vision, let's add life, disability, 401k. Let's bring all those things together. So during open enrollment, the message is to start with collective health, giving members one place to go. Not only is that easier for members, it's also one of the ways we drive engagement, because if you're used to going to collective health for everything, then when you need us, we are there. Or when we reach out to you, you know who we are. Another topic we could talk about, GLP-1s. The huge area of focus for us is understanding how we can work with some of the leading programs out there to really deliver a program that leverages collective health as a starting point, to really deeply plug it into our member experience. That could be a whole nother webinar. All right, maybe you and I will do that next month. A whole talk just on GLP-1s. But if you're curious, let us know. We can give you a preview on that. And then also because we're the administrator, we take a lot of ownership and responsibility of the employer and the consultant experience. One of the big areas of innovation for us is Collective Compass. That's our employer and broker consultant facing interface on how you run the plan and understand the impact. This year is going to be probably our biggest year yet of investments and updates to that. As I said, 10 years in, more than 600,000 members, it really feels like the pieces are starting to pick up steam. And this is how you start to make impact. And we'll end where we started. We would love to continue the conversation with y'all about how you can do both of those things, how you can put these puzzle pieces together to drive real economic value, $1,000 per employee of savings, but also upgrade the member experience at the same time.
Hey, Kirk, just to kick off the Q&A, and as a fast follow to that to your point you just made about connecting the pieces and sort of the puzzle piece slide, there's a couple that I feel like would be good. Can you talk a little bit about the way we work with various networks and the question about employer choice versus other underlying networks, and then the degree of Kaiser support?
Yeah, I'll take those ones, and then you get all the hard clinical questions. Sound good, Ari?
Deal.
So we work with many of the largest Blues plans that are out there today. So as you think about whether you're on the West Coast or kind of the central region or even the East Coast, Texas, Illinois, California. These are some of the areas where we have a lot of clients today, and we'd love to kind of continue the conversation with you. In terms of supporting folks like Kaiser, while we do not provide a lot of direct support on the member experience side of Kaiser, especially where I sit in California, it's very common for folks to offer a Kaiser plan alongside collective health. What we can do is we can help members understand how to connect to Kaiser. We can route them to the right places for Kaiser. And if they have a dental or a vision plan through collective health, we can deliver great service there. Ari, as you go through the questions, I know you've been tackling some, but do you want to hit any of the clinical ones more head on?
Sure. I started to in the chat. Actually, I haven't been monitoring both the chat and the Q&A separately, but the chat, I think we had a question from Mitchell about mentioning peak. So yeah, I did put a brief response, happy to entertain more detail, but we've built the provider quality as a generic solution. And what I mean by that is we can plug in different data sources. And this has there's a lot of reason for that. Some of it may be client choice. Sometimes we've had some, especially larger clients who have really strong opinions about the sources of their provider quality scoring and how they want to and like get really involved in how they want to construct a preferred provider tier, and we can support that. We have a couple of embedded solutions which include Peak, for those who may not be familiar, probably maybe everyone is on this call given the audience, but that's physician efficiency, appropriateness, and quality. It's part of the Blues national data set that includes, it's a Blues product in partnership with a third-party company that does the appropriateness and quality scoring on their behalf. So we have that embedded in our system, as well as some of the other independent third-party data sources.
Let me start tackling some of these as well. Let's keep them coming. How does collective health support or transition a current administrator to guide plans? One thing that's really useful to keep in mind is we do not think that guide plans necessarily needs to be a full replacement. For a lot of our membership, they offer maybe a high deductible plan, maybe a PPO or an EPO, and then a guide plan alongside of it. In fact, for a lot of our current clients, that's how they're thinking about it is let's roll out guide plans as one of the options alongside a PPO or maybe an EPO, and then let's get momentum over time. For a lot of our clients, what they're seeing is in year one, they get fair enrollment in a guide plan. But in year two, as the word of mouth starts to spread, that it's a better experience, it's a more understandable experience, then you really see growth there. I think an important takeaway there is guide is not something that sits outside of the core collective experience, or it is not this full carve out thing. It is one of the plans we support on the collective chassis, which really gives employers the ability to lever it up or down over time. All right, which plan elements are standardized versus flexible? Obviously, as a TPA, we support your plans, right? Our job is to make your plan comes to life. In terms of guide, what we really think about is a framework on how to make decisions. Ari, do you want to talk about within guide what some of those decisions look like?
Yeah, I spoke a little bit to it earlier, which is, I do feel strongly, to underscore Kirk's point first, which is that our job as the TPA is to administer the benefit to its intent, right? Within, of course, the limits of the law, for example. But we're not the plan sponsor and we're not the benefits consultant, and we recognize our swim lane there. But we like to be an active partner here, and I find that when those three parties, the plan sponsor, the consultant, and us can come to the table and talk about what the real intent is, we can talk about ways to meet that intent that are really member centric. And I think one of the things that tends to come up a lot for us is just this idea of like member agency of choice. Like, does the member actually have the ability to make this choice? And if the answer to that is no, for whatever reason, right? Like an obvious example that we wouldn't touch is like emergency care. Like that's not a time when you're going to really mess around with like, there's not a ton of choice in the ER that a member has about like who they're going to see, right? So you can't be like, oh no, you have to see Kirk because he's the best ER doc in town. You don't know when Kirk's on shift and off shift. So that's just a kind of an extreme example. Maybe that seems really obvious, but there's a ton of gray area, and we feel strongly that members have to be able to know what you're asking them to know at the time when you're asking them to make the decision. Otherwise, it's just not fair. And I think that helps simplify the design. I think it also helps make it more navigable for members, and avoid things like accidental sort of like financial penalties, right? Because you're talking about differential copays, and so if people don't know how to navigate that, then they can end up paying more out of pocket than expected.
A couple other things. You touched earlier on your care navigation being in-house. How is that different than some of the other third-party programs out there? I think it gets back to our core hypothesis, which is we think these programs work best when they're all connected. So as opposed to a third-party navigator who's having to get claims information from someone else, route you to someone else, speak to a plan design that they're not administering. Our belief is that if you're the care navigation team that sees the claims from the start, you understand the plan design, you understand how claims were adjudicated, you're getting that real-time information. We think that's a more effective, more understandable, and ultimately more satisfying experience. I think too often in healthcare, these different players feel like middlemen. Hey, I get to you, but can I really just talk to this person who has the answer? At Collective Health, the goal is we have the answer. Talk to us. Some questions around, can you bring in things like third-party program centers of excellence or kind of narrower networks? Yes.
Oh, yes. I think that's actually an important point. There's a ton of flexibility that we didn't really talk about. So like point solutions, program partners can be built into the tiering structure, as appropriate and as desired by the plan's sponsor and the consultants.
And again, I think we've beat this pretty hard, but the back end, front end. How do you bring in centers of excellence in the back end so the claims flows work? So it feels like part of the plan, so the data works. But for members, it's not like, oh, for centers of excellence, click on this other site to talk to this other company to see the centers of excellence. Just bring it into the core search experience. That's the value of having the back end and the front end together.
Yeah, and I see the question about point solutions we partner with. We've done hundreds of integrations. Um, this actually speaks a little bit to the flexibility we have, even with medical networks. Like, we can add medical networks now pretty quickly. That used to be a very laborious process. Program like a point solution integration is a couple of days. It's mostly just the back and forth to make sure we know what people want and have the right points of contact. But it's an operational configuration. There's no engineering work for us to add a claims level integration for a new point solution partner. So if we don't have them on the list, and we can share, maybe if someone can put in the chat, or as a follow-up, the link to our partner collective, which is a website that hosts all of our partner integrations, and sort of highlights various partners. We can, if we don't have them on there, we can add them very easily.
Speaking of member support, what languages can Collective Health support? From a digital side, our tools are fully native in English and Spanish. Same thing on the member service side. You'll hear us use the term member advocate. Those are our team members who are answering a lot of the benefit level questions. And then care navigation, that's our higher touch team. We also have member advocates that are heavily bilingual, and we can offer direct Spanish support, native on our member services side. I can tell you, we've had clients that have launched with as many as 50 supported languages. Typically, what we do is that native English and Spanish support. We then work with them to see, is there a next tranche? We'll call it 5 languages that are most prevalent. How do we bring that into our IVR from the beginning, from the member experience, so that we can create as authentic and natural as an experience as possible? And then we can use things like language line really tightly integrated in to do the long tail of the next 40, 50, 60 of the different languages. So I think that language flexibility is a core part of what we do. A couple other questions that I'm seeing, and keep them coming. We'll keep going. Talk to me, what types of clients do you work with? I would say our sweet spot is probably 1,000 employees to 20,000 employees. The folks that have an appetite to mix and match the pieces, but maybe have a challenge to do that themselves historically. We can go as low as 750 enrolled employees. We have multiple clients with more than 100,000 members. In terms of industry, one thing that we're realizing is it starts to be a little industry independent. Why? There's core human needs out there. The fact that we are a digital front door for folks that want to live life on their smartphone, fantastic. The fact that we are the one phone number you call if you just want to talk to someone, we're there. We're seeing increasingly it's manufacturing, it's food processing, it's retail, it's mechanical engineering, it's also white collar, tech, financial services. I think of it increasingly less of the industry and more of the workforce demographics. Are they in front of a computer? We have some people that work in fields. We have some people that are in front of a computer all day. What is the generational mix? Like most of y'all, you probably have 3 or 4 different generations in your workforce. Honestly, we see more of some of the regional variation of how we can really make sure that whether it's on our care navigation team, having social workers who understand the regional supports in your specific geos. I am curious what you think, but I'm increasingly seeing it not as industry specific.
Really have nothing to add to that. I totally agree, and I think for us, it really comes down to understanding the member population, which in itself is never a monolith, right? So like even when we say, okay, maybe there's a company that feels like it's mostly tech, but they also have some, I don't know, distribution workers or other low paid employees who some of whom are remote and rural. Like, I mean, so for us, understanding member needs and then understanding whether they're geographies, industries, or other needs about the logistics of their day. Like Kirk was saying, a lot of it comes down to like, I just have a quick break on the floor and I really don't want to call or log into a portal. I want to be able to text, right? So supporting really omni-channel outreach and both inbound and outbound communication with members is really our approach to making sure we can meet people where they are.
All right, maybe a nod for the future. There's a question about tell us more about GLP-1s. With
Yeah.
going deep in it, here's a couple of the challenges we see in the landscape. We know that they are expensive drugs. We know that members not only are struggling with the affordability of them, there are also distribution challenges. And I think too often when members start, then the anxiety kicks in of where am I going to get a reliable supply? We're also hearing on the employer side, y'all need a way to think about the cost as well. But is there a way to do it so it's not binary, covered or not covered? And also, what can you do to your members? So even if you're not directly participating in the financial side, how are you taking some of the lift off of them by making it as easy as possible for them to actually find a reliable source for some of these drugs? When we think about GLP-1s, we really think there are opportunities to potentially carve it out of the PBM into a separate benefit that then gives employers the ability to say, how much do you want to fund the benefit? Maybe you don't necessarily want to heavily fund it, but you want a really complete program that you can make available to your members so they get the support, whether it's clinical or distribution and sourcing that they need. But also let it be a chassis so as an employer, you can almost lever or slide the financial support based on what makes most sense for your organization. Those are the types of programs that we feel really put the employers in the driver's seat to say, how much of a financial contribution can we make? And independent of that, how can we make sure our members are getting the support that they need?
Yeah. I I think we'll probably have to leave it at that for today, but I would love to be invited back for a follow-up on that one. It's a hot topic.
And let maybe that Ari will let that be our nod for the future. Let's keep the conversation going. As I said, we would love nothing more than to continue the conversation with you and your teams live. I've said it several times. If you haven't thought about collective health recently, it's time for us to get back in front of you because innovation is really picking up here, especially as we hit scale. Thank you so much for taking some of your time with us today. Ari and I loved this conversation. Keep the questions going. Let this just be a kickoff to the conversation.
Thanks, everybody. Have a
Thank
great
you.
Wednesday.